Hello, everyone. Sorry I can't be there in person with you today. I'm Julie Highfield. Some of you might know me, but I'm a consultant clinical psychologist working in intensive care, and I'm the National Wellbeing Director for the Intensive Care Society Thriving at Work project. Today I'm here to talk to you about 3 helpful P's, how psychologists, professional nurse advocates and peer supporters can all work together for ICU staff wellbeing. Well, after years and years of working in wellbeing and being asked to define it, I've boiled it down to these 2 key sentences. Wellbeing at work is about doing a good job and feeling good about the job that you do. The end of the day, we know from all the experience we've had recently is that when something gets in the way of us doing a good job, we don't do so well. We don't feel good about the job that we do. Yes, there's more to well-being as a person because there's life beyond work. But when it comes to work, it's really about, why am I here? Do I enjoy why I'm here? Do I feel like what I do is a good thing? So how can we support people to do a good job and feel good about the job that they do? Well, part of that is feeling like you matter in some way. Part of that is being heard in your experience, being acknowledged in your opinion. Part of it is feeling that what you have to contribute is valued. We also see a lot, especially in an intensive care environment where there's so much going on. Have you ever got to the end of the day and someone says, "How was your day?" And you think, I don't know yet, because we're doing the whole time. We don't often have that space to think about what we've been doing. So we need that space to process, to think it through, to reflect on what we've done. We also want to learn as we go. We want to continuously improve, not in any forced way, but in a natural, progressive way where we just strive to get better and better and hone our craft. And we want to feel like we're not just a number, that we make a contribution, that we are cared for, that we are valued, but also that we make a difference to that patient and their loved one. And ultimately, we do that with good people around us. And one of the most important people around us is the person in charge, the person who's leading. Because if we like them, if they lead us well, we do an extra good job for them because we feel good about the job that we're doing. So just a quick one to think about mental health versus well-being. It's important to not think of well-being as an absence of mental health concerns, but we do need to acknowledge that work has an impact on people's mental health. So labels that people will talk about that I won't go into great detail today, but people talk about general psychological risk, moral distress, that difference between the care we want to deliver and the care we're able to deliver causing distress, trauma, which is where an experience sticks with us and intrudes in our mind and keeps coming back to us. Burnout is where we feel like we've given too much and disconnect to cope. There's 2 main ways in which the work affects those and triggers those. One is the work in of itself, so whatever happens around that patient that we kind of expect but is still nevertheless harrowing and difficult, which we call the primary stressor of work. And 2 is the secondary stressor, which is all the things that get in the way of us being able to do a good job. And I'll go into detail of that in the next slide. So what's the answer? Do a good job and feel good about the job that you do. So we're doing what's right for the patient, and we learn when we get it wrong, because we will, because it's healthcare. That our focus is on the patient experience, that humanization, that dignity, and in some cases, a good ending, a good end of life care. And all that time while we're dealing with this difficulty, we feel like we're managing ourselves, our own emotional burden. We're managing the demands of the work. There's enough of us to go around. We get on with our colleagues. We know our colleagues, and there's good teamwork, and we feel valued and we feel supported. Because the primary stresses are death, disease, distress, demands, the difficult team dynamics, and the differential diagnosis and disagreements. But those secondary stresses, the things that we could all do without, the lack of resources, the failing systems, poor leadership, unhelpful bureaucracy, excessive demands, poor infrastructure, problems with the rota and staffing, they are all there, and sadly they're going to continue for a while. The NHS is always going to have these problems. So when we think about the inevitability of some of that, we have this core strategy for supporting staff, which is part of the work that we're doing in the Intensive Care Society, but it's part of what I do and what I believe in on a day-to-day basis, and it's based on rigorous evidence, which is in essence what we want to be doing as much as possible is we want to prevent harm from coming to the staff in terms of managing the way in which we approach the work. We also want to prepare staff. We want staff to know what they're signing up for and feel emotionally prepared and able to manage the work that they do. And we want to keep at that next level, we want to keep that in a maintenance cycle. So there are things that will inevitably crop up. So we want to nip those in the bud as quickly as we can to maintain the health and well-being of our staff. But sometimes things will go wrong, so we need to be responsive to that to restore people to their core baseline. So this is a really important three-part strategy, and it's sometimes called the primary, secondary and tertiary level intervention. And what we find, a lot of health and well-being strategies are about responding and restoring. So psychological therapy is very much about responding and restoring, or it's about ignoring the problem completely but doing something nice that feels good, which is lovely, but it kind of doesn't, it's a cork in a tub of bathwater, really. It doesn't particularly work for very long, although it feels good for the moment. So PNAs, professional nurse advocates, well, I'm sure most of you know because a lot of the audience will be professional nurse advocates. So it's a master's level training aimed at nurses. It's become particularly focused in critical care since the pandemic, but it originates in midwifery and health visiting. It's based on two core premises. One, which is the original one, which is the idea of restorative supervision. It's an idea that actually comes from clinical psychology because the professional nurse advocate role was developed hand in hand with clinical psychology. So the idea within restorative supervision is that we spend time reflecting on our clinical practice. So the PNA listens to and understands the challenges and demands of their fellow colleagues. And in restorative supervision, we use listening skills to hear that and to reflect upon that. And then on occasion, there will be ideas that come forward from that, where a QI approach is used to deliver quality improvement initiatives in response to any particular problem area. What I'm very aware of is, although this is the core premise of the PNA, a lot of people who've chosen to train as PNAs have a general interest in well-being, and so are taking it upon themselves to lead on well-being on a number of different factors. I would actually say we have to be a little bit cautious about leaving those people in isolation. A master's module is good, but it is not a complete grounding in mental health or what goes wrong with well-being. And I think we can put too much expectation on one individual to deliver and be responsible for well-being, when really well-being is an incredibly complicated area. So I think there's a lot to be said for how we as psychologists can support our PNAs in supporting the wider staff wellbeing. So for psychologists, I am one of them. We have lots of different types. We all train for a minimum of 6 years to doctorate level, trained in all aspects of human psychology across the lifespan, and we use multiple models of psychological assessment and intervention. The protected title is clinical psychologist through the HCPC, but the common types are clinical psychologists such as myself, counselling psychologists, health psychologists. So Dorothy Wade, for example, is a health psychologist. And in the NHS, usually the kinds of settings we go into are mental health settings, learning disability, hospital and health settings, and specialist areas. So there's lots of people that go into kind of niche areas. So a good way of comparing us is a lot of the time we're considered sort of comparable to physiotherapy, OT, etc. in terms of being therapy, but actually our specialism is probably a little bit closer to that of doctors in terms of medical area or population area. And also our length of training is actually equivalent, and most of us, because we're trained to doctorate level, do actually have the doctor title. And if you're lucky enough to have a psychologist in your intensive care, about a third of the UK does now. When I first started, there were 11 of us. Now there's over 100 of us, but we get involved in the family work, the staff work, the patient work, and the system work. So we will work in terms of direct intervention and around working around the patient, from everything from delirium, engagement, rehabilitation, mood, working with patients post ICU, in recovery, in the follow-up clinic and on the ward. We also, of course, work with their families around best interest meetings and working with the family distress and trauma. Some of us get involved in bereavement work, and some of us are involved in kind of smoothing out some of those relationships with the ICU and families. Of course, as well as staff well-being, we're also involved in teaching staff psychology skills, working with them in terms of post-event team reflections, offering supervision, offering training, as well as many of us work across that whole system in terms of trying to help shape the way we work in intensive care and offering that visible psychological model in a leadership role, as well as getting down to the nuts and bolts of being involved in service design and SOPs. So it's a broad role and we're capable of doing lots of things, and I think it's important to think about that kind of overview that we have. But there's a key link to the PNAs in terms of working alongside and supervising those PNAs in what they do. Restorative supervision is something that comes from the discipline of clinical psychology, so it's something we practice all the time, and it's embedded into our training as well as other models of supervision. But we're also there thinking about the peer supporters and looking after them in their role. So peer support, what is that? Because this feels like probably a slightly less known area, but I know because of working with Karen Wilson, we've got a lot of people in your area that are signed up for peer support training. Well, peer support is where you have two people in the same situation who offer supportive conversations within that context of work. So I am your peer, you are my peer. We are in the same collegiate situation, and the support is that supportive conversation. A key difference with PNAs is we train any MDT member. It doesn't have to be a nurse, although given that we have more nurses than anyone else in ICU, we do have a lot of people who are nurses who are signed up. It's a supportive relationship and the intention is mostly one-to-one, but it's flexible. the common work experience and talking around work experience is the focus of the peer support conversation. So similar to restorative supervision, but actually it's broader in that it doesn't have to be about reflecting on the clinical nature of what we do. It can be broader than that, but I'm sure there's a lot of people in the PNA role who broaden it to more than just the clinical work. And the idea is that it's a support both emotionally and socially. It is originally trained as a one-to-one relationship, but what we've found over time is we flex this to group models and we flex this to different kinds of settings. So we've done things like coffee mornings, walk and talks, going for a picnic, we've got a running club, those sorts of things now as well. So of course I'm going to advocate for the Intensive Care Society's peer support model, which was derived by these two beautiful people. So Prof. Richard Williams is a psychiatrist from the Bristol area who works for the Royal College of Psychiatrists and led on their COVID response, but works with a lot of pre-hospital emergency medicine. And then we also have Verity Kemp. She is the lady who's an emergency planner and she's responsible for the levels of care approach that we have in intensive care. So there's her intensive care legacy, if you like. So the two of them have been honing their peer support approach for years. I trained with them when we trained the Welsh Air Ambulance in this model, and then I brought this model into the Intensive Care Society. There are two other really well-known models. So TRIM refers to itself as a peer support model, although its premise is largely assessment-based. So it's meant to follow on from a single incident trauma at work. The TRIM team have now developed something called STRAW, which is supporting resilience at work, which is more akin to our intensive care society model, interestingly enough, and it's that one-off conversation about looking after well-being. Mental health peer support is also an area of peer support, but the shared experience is actually the mental health. So it's a non-work based peer support model. So there are clear guidelines for this, and there are 6 key elements that need to be in place for peer support. So number 1, the peer support session has to have a clear goal. The peer supporters, number 2, have to have definite roles. Number 3, they need to be selected. Not anyone can do it. Number 4, they have to be trained. Number 5, they have to have ongoing access to clinical supervision, so they're looked after and they have support. And number 6, there's continuous evaluation of the work. So the peer support training is a one-day online training with myself and a team. We very much expect people to sign their unit up or the region up, just because it's really unsustainable to have just one peer supporter in your system. We teach people lots of practical skills around supportive conversations across the day. We also talk about the theoretical framework of well-being and teach people to be trauma aware, some psychological first aid skills as well. So to just give you a flavour of some of our outcomes, we know from our data so far that mostly it's females that access this service. 83% of those accessing the service are from a nursing background. And there's a mixture of experience, with almost half of them being longer term ICU professionals, if we do count 5 years plus as longer term, depends on your frame of reference. A couple of quotes there. It's nice to have someone ask how you're feeling. It's great to talk to someone who's been through the same experiences as me. So very much people reporting that they feel heard, that they feel that the discussion is relevant, that it's a good fit, and that it has helped overall. So just a quick comparison across the three Ps there. So your practitioner psychologist is trained for 6 years to a doctorate level. Your PNA has a nurse background and then does an additional master's model. A peer supporter comes from any MDT profession, so they have their core profession and they have a one-day training with us at the Intensive Care Society. So how do we as three Ps work together? Well, I think there is something about having those peer supporters as that wider supportive well-being conversation. There's also something about little p peer support, non-trained peer support, in that we should just look after each other anyway. But having those formalized peer support, a capital P peer support roles in part of that kind of preparing people for the work and having a preventative approach. PNAs offering that restorative supervision, routine places for people to discuss the work, and that opportunity to link to QI is very much in that maintenance phase. This is very much about we should just be talking about the work anyway. We shouldn't wait for something to go wrong. But psychologists can work well when something goes wrong. They can work well when mental health has been triggered, and they can work well in those post-event team reflections. So also they can work well to support the PNAs and the peer supporters in anything that they're witnessing and building on their skills. So really the three of us can work together in terms of staff wellbeing, working across the system. And I think for me, over time in my unit, what I really wanted to build up was this idea of well-being is everyone's business, and it's just what we do. What we do around here is socially embedded. We look after each other. And trying now to build in a routine sense of let's talk about our practice. It's just what we do. So that model of restorative supervision routinely being brought in. Finding time for that is a tricky one. And then I'm there really when all else fails and when it goes wrong. That's not to say I can't help as a practitioner psychologist in those preventative and maintenance levels, because I'm very much there alongside. But actually, it's good to have that higher level response if needed. Obviously, if you don't have a psychologist in your ICU, hopefully you have a connection to your wider hospital psychology team, or potentially to your employee wellbeing team or primary care mental health services. And then finally, I was starting to think about the challenges that each of the P's faces, potholes for P's, I thought I'd call them. And then I realised that we all have the same thing in common. So number one, being taken seriously by the system. I remember when I started in ICU and people were like, why are you here? We don't need a psychologist. All of our patients are asleep. And actually over time, here I am in a national role promoting psychology in intensive care. It has taken a while for people to get their heads around psychologists in ICU. Same goes for PNAs and peer supporters. Time and resource to meet, people putting aside that time to value this. The expectations that despite we're here, we're not miracle workers and we can't do it all. And ultimately, we are not a good substitute for doing the job properly in the first place. And a big part of that is working conditions, and another big part of that is your team leader. And I think particularly for the PNAs and nurse leadership, sometimes I think to myself, actually, if we had given our band sevens and our team leaders time to look after our staff well, then the restorative supervision might have occurred naturally. But we don't often support that. We've had to almost designate a role to give the system permission for it to happen. And of course, we all also have other things to do. I, as a psychologist, am seeing patients and families as well. I've got a follow-up clinic. I manage other psychologists. I don't just work in intensive care. You, as nurses and members of the MDT, you've got a clinical job to do alongside your peer supporter and your PNA job. And then ultimately, it doesn't matter how many years I've trained versus 1 day training for peer supporters. Actually, we need support. We can't do this in isolation. We can't do it on our own. We need to be developed to be developed in that role, to support this role going forward. But ultimately, I believe that there's space for all three Ps in ICU, and I hope in the future that all three exist. Thank you very much.